Good afternoon, everybody. My name is Ben Tomczyk. I'm the Deputy Chief of Staff at the Committee for a Responsible Federal Budget, a nonpartisan think tank focused on analyzing and improving our nation's fiscal policy. We're really excited to have you joining us this afternoon. Thank you so much for taking the time to help kick off our event on new ideas to lower healthcare costs, which is part of our Health Savers Initiative. The Health Savers Initiative is a joint project of the Committee for a Responsible Federal Budget, Arnold Ventures, and West Health, which works to identify bold policy and concrete policy proposals to make healthcare more affordable for the federal government, businesses, and households. To kick off today's event, I would like to now introduce our collaborators from our partner organizations who will be giving some opening remarks. First, we will hear from Christina Bocuti, Director of Health Policy at West Health, and then we will hear from Erica Socker, Vice President of Healthcare at Arnold Ventures. Erica and Christina, thank you so much for joining us this afternoon.
I'm thrilled to be here, and I want to tell our audience who may not be familiar with West Health that we're a family of 3 organizations with a very unique mission, which is to lower healthcare costs to enable successful aging for American seniors. At our heart is the Gary and Mary West Foundation, which supports research and analysis at the West Health Institute, which is in San Diego, and the West Health Policy Center in Washington, D.C., where I am. So I'd say fundamentally, West Health connects the areas of applied medical research and policy analysis and outcomes-based philanthropy with a focus on successful aging and healthcare costs. In our work, we've concentrated on 3 common sense reforms to lower healthcare spending for both public and private payers. Our first focus is on lowering prescription drug prices. We've launched several projects to examine the impact of drug costs on American households and policies that could be implemented to lower them. As you've heard in survey after survey, millions of people are skipping doses because they can't afford them. And even when they have insurance, they're facing these problems. In fact, research at West Health has found that under current trends in drug pricing and cost sharing, skipping drugs due to cost will result in premature deaths of over 100,000 Medicare beneficiaries a year through the next decade. So that means that lowering drug prices will not only save Medicare hundreds of billions of dollars, but it will also save lives. A second area that we're focusing on is accelerating value-based payment models. These models align with clinicians who really want to prioritize high-value care in their practice. In COVID, we've had the opportunity to learn that medical practices working under value-based payment arrangements were more resilient and much better equipped to innovate. They had the infrastructure to track their patients and reach out specifically to those with the highest medical needs through telehealth and other creative interventions. So we've recently partnered with US of Care on a playbook that considers ways to integrate telehealth into a value-based payment model. And we're also working with a great team at Duke Margolis Center for Health Policy to find ways to promote faster adoption of value-based payment in practice. And our third area of focus is on increasing price transparency in healthcare, something that isn't a solution by itself, but a necessary condition to lowering overall spending. After all, price gouging needs to be exposed to find ways to address it. Some progress has been made in this area, but more can be done. I also want to say that working with the Committee for a Responsible Federal Budget and Arnold Ventures on this Health Savers Initiative has been a truly collaborative project. And I'm thrilled to be here today with both organizations to engage on ways to lower national healthcare spending. We know that Medicare solvency is an urgent issue before Congress, and we can expect legislative action to address it. But the issue of healthcare spending really goes beyond the Part A trust fund. A smart package would contemplate a broader set of reforms. So with that, I guess I turned it over to you, Erica.
Thank you, Christina. And thanks everyone for joining us today. I'm really delighted to be here. Christina did a nice job teeing up the issue of rising healthcare costs, why you should care, and some of the specific areas policymakers should be focused on. So what I want to do is just add and emphasize a couple points that she mentioned. One is that there's broad agreement among the public and policymakers that healthcare is unaffordable. We pay about twice as much as other countries on a per person basis, but we're not getting sufficient value for the amount that we're spending. And so the question then is, what do we do about it? And there's less agreement here. Part of what we are trying to do with this project is to start building more consensus, both on what areas of spending we should be targeting to make a real dent in costs and what some of the most effective solutions might be. Policymakers have been focused on the pandemic and on providing economic relief most recently, and that's a reasonable thing to do at the moment. But in the coming months, we need to turn back to the issue of high healthcare costs. The pandemic has not fundamentally changed the inefficiencies and pricing problems that exist in our system. Those will still be there on the other side of this. And reducing healthcare costs has the added benefit of freeing up money that could be used to pay for other health priorities you might have, like expanding benefits and coverage. Enacting reforms that reduce healthcare costs is challenging. There's no doubt about that. It involves making trade-offs and ultimately taking money out of the system in certain places. But we can't afford not to deal with the cost problem. What we're trying to do at Arnold Ventures is make the job of addressing healthcare costs a little easier, hopefully, by generating the evidence, developing viable policy solutions, and providing the technical assistance that's needed to advance effective policies to improve affordability. And for us, that means making healthcare more affordable for everyone across the system, for consumers, for employers, and for the government. To achieve this, we can't simply shift around the costs that people and purchasers are paying. What we really need more focus on is bringing down the underlying cost of healthcare. So our work focuses on some of the key drivers of those underlying costs. In some cases, as Christina already mentioned, the issue is that the prices we pay are too high. This is the case for both hospital services and for prescription drugs. These are places where market failures and a lack of competition allow providers and drug manufacturers to charge excessive prices. And then in addition to our work to lower prices, we have a newer initiative, which I'm excited about, which is focused on putting the Medicare program on sounder financial footing. Medicare's Hospital Insurance Trust Fund is projected to run out of money in 2026, as Christina noted. But even setting that problem aside, the Medicare program faces longer-term fiscal challenges that must be addressed. And these are not limited to the Part A hospital benefit. So we really should be thinking comprehensively about ways to make the Medicare program more efficient and less costly for beneficiaries and for taxpayers. We've partnered with the Committee for a Responsible Federal Budget and West Health on this Health Savers initiative that Christina raised, and that's part of the basis for today's discussion. Our goal here was really twofold. First, to put forth actionable policy solutions to lower costs in Medicare, as well as in the commercial insurance market. And second, to give you some information about what those policies mean and the associated savings, not only for the federal government, but also for total spending and for families. The options we put out so far highlight specific opportunities that would make a meaningful impact on costs, and that are places we think policymakers should be looking for savings. It's been a wonderful experience to partner with both the Committee for Responsible Federal Budget and West Health. We're very aligned in our goal of cost containment, and we're also aligned in our interest of advancing pragmatic policies and starting to build bipartisan support around those. I hope that today's event contributes to the ongoing conversation about healthcare costs. We have a set of great panelists, so I'm looking forward to hearing what they have to say. And I hope that you are able to come away from today's event with a better sense of some concrete steps that we could be taking to contain healthcare costs, perhaps even some policies that could be enacted this year. And now it's my pleasure to introduce messages from Senate Finance Committee Chairman Ron Wyden and Senate Finance Committee Ranking Member Mike Crapo. The Health Savers Initiative has a bit of a tradition at this point, where the leaders of the Senate Finance Committee come and speak at our events. Senators Wyden and Grassley were at our launch event for this project that was at the end of 2019. It's great now to introduce Senators Wyden and Crapo, who we know take healthcare and fiscal issues seriously, and who we hope will work together on these issues in the coming Congress. Chairman Wyden will be speaking first. Thank Thank you.
Thank you for inviting me to speak with you today. One of the great challenges in America is lowering the cost of healthcare. Our country spends too much, and it doesn't spend it in the right places. I appreciate your efforts to identify ideas to lower healthcare costs. There's a big debate coming, and it's critical to have an array of new policies at the table. I thank you for your interest in our efforts to lower health costs by addressing the high cost of prescription medicine. I'm proud of the bipartisan work I did with Senator Grassley in the last Congress, and I'm planning to build on that work now as chairman of the Finance Committee. Keep up your efforts, and I look forward to continuing the conversation.
Hi, I'm U.S. Senator Mike Crapo, Ranking Member of the Senate Finance Committee. Thank you to Maya McGinnis and the Committee for a Responsible Federal Budget, and members of the Health Savers Initiative for the invitation to speak to you all today. Maya and I go back a number of years. It's always a pleasure to connect with her, though I look forward to a day when we no longer need to talk about debt and deficits. There is much work to do before we get to that point. My healthcare priorities as ranking member reflect this task. Updating Medicare payment systems to foster innovation will improve patient care and efficiency. Addressing Medicare's financial problems will make the program sustainable for current and future beneficiaries. While the COVID-19 pandemic has tragically threatened Americans' physical and economic health, it has also reinforced the value of innovation and provided an opportunity to test changes that foster it. Medicare beneficiaries have benefited from access to telehealth and expedited approval of COVID-19 vaccines, diagnostics, and treatments. We must evaluate the flexibilities that have assisted patients during the pandemic so we can make appropriate reforms based on the lessons we have learned. We also have an opportunity to make payment changes in key areas while preserving the role of the private sector in Medicare. The Medicare Part D prescription drug program, which is built on a system of private entities competing on price and service, has provided seniors a variety of drug plan options while keeping premiums remarkably steady. Part D has also furthered the United States as a pharmaceutical research and development powerhouse that produces life-saving therapies. However, drugs are only effective if patients can access them. Last Congress, I introduced the Lower Costs, More Cures Act to ensure Medicare prescription drugs are both accessible and affordable. My bill would modernize the Part D program to reduce incentives that may encourage growth in list prices, account for innovation in the prescription drug marketplace, and protect patients through an out-of-pocket spending cap. The bill shows that we can lower prescription drug costs for patients and taxpayers by increasing private competition. Price controls and other government interference would decimate pharmaceutical innovation and be counterproductive. Expanding telehealth, increasing efficiency through innovation, and modernizing the Part D program are examples of bipartisan steps we can take to improve Medicare and reduce spending. The precarious state of Medicare's finances, however, indicates that even more needs to be done to ensure the program's long-term viability. The Medicare trustees currently project that the Hospital Insurance Trust Fund will go broke in 2026, though the impact of COVID-19 could move the insolvency date even closer. While I did not support Attorney General Becerra's nomination for HHS Secretary, I expressed interest throughout the process in working together on areas of common interest, including improving Medicare solvency. Mr. Becerra agreed he would have the Medicare actuaries provide an updated estimate of the HI Trust Fund insolvency, date 1, that accounts for the impact of COVID-19. I also made it clear that I expect HHS to submit a plan for extending HI Trust Fund solvency to Congress in the near term. The Biden administration should work with Congress in a bipartisan way to ensure that Medicare is able to serve current and future beneficiaries. CRFB has long played the role of encouraging this kind of bipartisan action. The CRFB Health Savers Initiative is another step with a much-needed focus on saving Medicare and addressing the broader healthcare cost problem. And while I may not agree with specific policy recommendations, the initiative is constructive in highlighting the need for bold action. I look forward to working with CRFB and its partner organizations to create the environment for bipartisan action in the 117th Congress. Thank you.
Thank you so much, Christina and Erica, for those remarks. I'd now like to introduce the moderator of today's panel, Joanna Keenan from Politico.
Hi, everybody. Thank you for joining us. We're going to start. Let me start by introducing our panelists. We're going to try to keep this pretty fast paced since, we all live too much on Zoom. We're going to talk about starting with some ideas that the committee has put forth in some interesting issue briefs, and that'll be our starting point, which we'll hear about in a moment. Then we're going to turn it to more of a conversation, and I will be working in some of the questions that you guys are putting in the Q&A. So to start with our guests, Josh Gordon is the Director of Health Policy for the Committee for a Responsible Federal Budget. He leads the research on health policy and the healthcare system, and he's spearheading the Health Savers Initiative, which is really sort of the guts of what we'll be talking about today. And of all the panels I've done and all the guests I have introduced, I don't think I have ever gotten to say that he was a research advisor for the Sundance Film Festival documentary I.O. USA in 2008 before going on into his academic career. Mike Chernow, many of you are familiar with. He's the Leonard D. Schaefer Professor of Healthcare Policy and the Director of the Healthcare Markets and Regulation Lab at Harvard Medical School. He is an expert on all aspects of healthcare, but particularly Medicare and its costs. He is the chair of the Medicare Payment Advisory Commission, or MedPAC, and he wants me to stress, and he will probably stress that again himself today, he is speaking here as Mike Chernow. He was not speaking here on behalf of MedPAC. And Tricia Newman, who is someone I have learned a lot about Medicare from over the many years I've been trying to understand Medicare. She's the Senior Vice President of the Henry J. Kaiser Family Foundation, the Executive Director of Kaiser's Program on Medicare Policy, widely cited, worked on the Hill long ago, and she'll be talking about all the things we're talking about today, including a little bit about drug prices. So I'm going to turn it over now to Josh, who's going to get us going with three topics that the committee has sort of brought into relief, and then we'll take it from there. And I've learned after we've all done this for a year now, everybody has internet speeds that have minds of their own. I'd start with a blanket apology. Anyone who talks over anybody else, you blame it on your router. Josh.
All right, thanks, Joanne. And I also want to thank Mike and Tricia for showing up here, and of course for the audience tuning in. I want to thank Erica and Christina, who you heard from earlier, who with their organizations have been really great partners and collaborators with CRFB on the Health Savers Initiative. I also want to recognize Duran Impresso here at CRFB. Sarah Goodell also helped with research and writing on our issue briefs. Professor Rick Cronick helped design and write our option on Medicare Advantage, which I'm about to talk about. And I also want to thank Holly Harvey, who helped CRFB start this initiative back in 2019. So the Health Savers Initiative you heard about, one of the things that wasn't mentioned was what we're really trying to do is take ideas from the think tank community or health policy researchers and try and translate them and talk about them on the Hill. And so we do that by writing issue briefs, and I'll talk about the three that we recently released, but we also try and put scores on these options because, the Congressional Budget Office obviously does a great job of scoring for federal budget impact, but sometimes these policies have an impact beyond just the federal budget, and we wanted to capture that and talk to members of Congress and their staff about that because you can save money for the federal budget, but move costs onto the commercial market or onto states. And so we want to capture kind of the holistic view of some options that can save money, not just for the federal government, but for commercial insurance, for businesses, and for individuals. And we think we kind of capture that in the three options that we first worked on. And we're also looking for options that can really capture some market failures or inefficiencies or perverse incentives and try and make health policy a little bit more sane. If we could kind of redesign these things just a little bit to make more sense, we try and look at options that do that. So let me talk about our three options really quickly, and then I'm sure I'll talk a little bit more about them during the panel discussion. The first option we looked at was moving to site neutral payments in Medicare. This actually is a pretty old idea. It's also a bipartisan idea. Both Presidents Obama and Trump had this idea in their budget submissions. And right now, Medicare pays differently for the same procedure depending on where you have it done. If you have it in a hospital outpatient department, if you have it in a surgery center, or if you have it in your doctor's office. And this really doesn't make a lot of sense. And it also costs Medicare about $150 billion over the next 10 years. But what we also find is that because Medicare does this, private insurance companies do this. And we also find that this payment disparity increases consolidation in the healthcare market because you have hospitals buying up physicians' offices in some part to take advantage of this disparity. So we think reversing this, just having Medicare reverse this, might also convince the private sector to change here, which could bring anywhere from $300 to $600 billion in additional savings, which translates into lower premiums and cost sharing for individuals in Medicare and for individuals on commercial insurance. And this is one of those really good examples where how Medicare payment policy is really important for the overall healthcare market. So it's worth looking at. Another thing we looked at was overpayments in the Medicare Advantage program. And this is something that Rick Cronick worked with us on. And it's an issue that also is pretty well known. Congress actually has tried to get CMS to adjust for these overpayments over time, but we think they're just not adjusting enough, because what's happening is there's this, again, kind of perverse incentive where the private plans in Medicare Advantage get paid more based on how many diagnoses for their enrollees they're able to put down on a chart, basically, because we want insurance plans to get paid based on the health of their enrollees. So there's this incentive for Medicare Advantage plans to code kind of frequently and intensely. And fee-for-service Medicare doesn't have those same incentives. So on paper, when we decide how much to pay Medicare Advantage plans, we tend to pay them a little bit more because their enrollees look a little bit sicker than the fee-for-service population, when in reality, they're not actually sicker. They just look that way on paper. So we think that if we more fully adjust for this policy, we could save some money for Medicare, we can save money in premiums, and also you can save money for the Medicare Trust Fund, which I know was mentioned, and I'm sure we'll talk about in a little bit. Trust fund insolvency is on the horizon, and we need to take as many opportunities as possible to extend that solvency. And the final issue brief we wrote was about capping hospital prices. This is a little bit of a bigger issue than the other two, and is not something that can easily be done. And we're not really suggesting the government should step in tomorrow and start capping prices for what hospitals can charge commercial insurance. But what we do want members of Congress and their staff to understand is how much money is out there because of the pricing power that hospitals have. On average, hospitals charge twice as much as Medicare. We found over 100 hospitals that charge between 300% and 400% of Medicare on average. So this hospital pricing, I think, just represents another market failure in our healthcare system, where because hospitals are kind of must-have hospitals in their region. Insurance companies have a hard time keeping them off of their plans, which means that they can demand higher prices. We also have regions in this country where hospitals have a lot of concentrated market power. So this is one of those things where we need to do something about. And I know Mike has ideas about some of the best ways to attack this problem, but it's definitely something that Congress needs to start thinking about. You could save almost $1 trillion in national health expenditures over the next 10 years if we just kept prices at 200% of Medicare. And there are obviously ways to dial that up or down depending on where we want to go, but it's an area that we need to start looking at for health savings. And with that, I'll turn it to Mike.
Mike, as you take this up, I think it's hard to tell who our audience is on Zoom. I think it helps to sort of just briefly explain the differences between capping and price setting.
And I will do that, but I have to thank a bunch of people first. So I'll thank you, Joanne. I want to thank West Health and Arnold Ventures for both putting this on and other support, and obviously the Committee for a Responsible Federal Budget. I'm really honored to be included, as well as Senators Wyden and Crapo for their participation in this event. I've spent a lot of time in my life trying to think about how to provide fiscally sustainable, high quality care, and it's great to have the audience here, at least virtually. So as you said, Joanne, I am speaking as me as a professor, not me as a MedPAC chair. It's important to understand the distinction. And I had a bunch of notes, and now I'm going to save a little bit of time because they're so aligned with what Josh said. I'll make a few basic points. First is, it's really important that we don't talk past each other by confusing whether our problem is total healthcare spending or public healthcare spending. I'm largely going to talk about total healthcare spending. When we talk about price issues, for example, it's largely in the commercial market, but understand that a lot of the problem is in fact public spending, in particular this concern about the Medicare Trust Fund. I will add that while the Medicare Trust Fund has indeed been challenged by the COVID pandemic, as many things have been, the providers have been challenged, the economy's been challenged. It's also important to understand that the core Medicare problem in many ways is demographic. And so when we try and figure out what to do, we're fundamentally trying to figure out how to finance a changing demographic. How are we going to support more beneficiaries with fewer workers? And that requires more efficiency, which gets to another theme that you mentioned, Josh, which is our goal is not to lower spending. Our goal is to spend more efficiently. Several people have echoed that. And I think that matters a lot. Therefore, in much of the work, particularly in the commercial market, focus on market problems as opposed to just getting spending down. And the last point I'll emphasize, which comes, I think, probably pretty clear to everybody, is there's not going to be a magic bullet. So if people are on the line hoping that we're going to tell them pass this one bill or this one law, and then we can go on to the other number of other myriad of problems we face, that's not true. This is going to be a multifaceted solution to a very, very big problem. So we'll talk now, as you suggested, about high prices in the commercial market. And I'll start with what you asked, Joanne, which is the difference between price setting and price capping. So price setting is an example where you might say the price for a knee surgery will be blank. That's largely how Medicare works. We set the prices for different services. There's fee schedules. Price capping is more designed to allow the market to work and step in as what we call a backstop when you think the markets aren't working well. So I have a proposal with my colleague Limor Daphne and Max Pawnee that was part of the Hamilton project from Brookings that talks about one way to do this. We focus on price capping, which again, I emphasize is very different than price setting. We set, in our model, we set a much higher cap than you would see in the issue brief, but I know you didn't pick a particular proposal there, Josh. But the point is that that allows the market to work in a bunch of places, and you want to just get rid of the most, what you think is the most egregious problems where you're least worried about disrupting the markets. And I think that overall matters a lot. So again, our proposal focuses on price capping, not price setting. There's a few other things we do in our proposal. I'm not going to go through all the details. One of which is to focus on price growth, not just price levels. So the problem with capping is there's a lot of stuff going on underneath that. Rhode Island, for example, has a program that's been successful, is evaluated that looks at price growth in a bunch of ways, and I think that matters. And we can get into more detail, I'm not sure how much you want to, about how it gets enforced and making sure that this is administratively feasible. I'm only going to really mention two other quick things as we go through that. The first one is, so that's about prices. There's a broader issue about low value care. We don't want to reduce utilization. We just want to reduce low value utilization. I just want to call out that there actually is a provision in the ACA section 4105 that allows Medicare not to pay for low value care. That hasn't really been implemented. There's some estimates I've seen from some colleagues at Michigan and others. It's about $5 billion over 10 years. So it's not a ton of money, but it's a move in the right direction to begin to do that type of work. I spent an enormous amount of time thinking about alternative payment models and what might happen in Medicare and the commercial sector, so I won't talk about them, but I think Christina emphasized at the beginning a point which I will echo, which is we need to think about what the incentives are in the system overall to make providers give efficient care. The core issue here is we need to provide care less expensively so we can then therefore pay less for it. Is really the providers are central to this whole system. And so the challenge is how do we give them the incentives to be efficient and then support them in what to do so we can get high quality care for what we can afford. And that, I think, at its core is the case for a bunch of payment model changes. I won't take the time now to discuss my preferences there. Maybe we'll talk about it on the panel. Instead, I think it's probably better to turn it over to Tricia. So,
Trish, go ahead, and then we'll come back and open a conversation.
Okay, thank you. And I also want to give all of my thanks to the committee, to West Health, to Arnold Ventures, to Joanne for moderating the three of us, and to Senators Wyden and Crapo, who set up this discussion so well on this topic, which actually is a tough topic because really nobody likes the idea of reducing costs. It's much, or I should say, it's much easier for policymakers to talk about spending money than cutting costs, and for good reason. I think everybody understands that when we talk about ways to reduce spending, that has the potential to affect the providers in their district, the constituents in their district, and having some sensitivity to that in the midst of a pandemic is, of course, very important. However, not talking about healthcare costs, high healthcare costs and rising healthcare costs has its own cost, because high healthcare costs directly affects affordability for employers, for consumers, employees, workers, families, the 60 million or so people on Medicare, and taxpayers. So while this is a little bit like eating spinach, as some have famously called it, it's actually really important for the dessert of helping to lower costs and making it more affordable for people and employers in the end. So that's why I think this is an important discussion, a particularly important discussion, and I thank you for hosting this. I want to take a few minutes to talk about the ideas that Josh has put on the table, and also mention prescription drugs, which wasn't in this particular package of Health Saver papers, but I think is important. And also what I do want to say is I thought these were three very excellent, well-written papers that laid out the issues and the trade-offs very, very, very clearly. So I appreciate that. I'm also not going to talk that much about the trust fund because I suspect that's going to come up in the Q&A, but several of these proposals, but not all, do circle back and affect the trust fund directly. On the topic of capping hospital prices, again, I thought that was a really interesting paper. We know that high commercial prices relative to Medicare prices has a direct impact on affordability for employers and employee premiums and for people in the marketplace. We at KFF did a literature review because a lot of people have looked at the price differentials between private insurance and Medicare, and we saw quite a range, but basically what we saw on average across the studies is something like a 2-to-1 range for inpatient hospital services with outliers that were considerably higher, as Josh, you mentioned. And then for outpatient, we saw the ratio was even higher. The average was 264% of Medicare rates across studies, and up to 358% in one of these studies. So it is a fact that there are higher prices in the commercial market, and that directly leads to higher premiums for employers and employees. So we were curious once we saw this as to what the effect would be, and we took a slightly different tack than what the committee did and with its partners in looking at what would be the effects of lowering prices to Medicare rates. And I want to say at the outset, this was illustrative. We weren't putting out a proposal. We weren't making a recommendation. We were trying to make a point. And what we saw is that if, all of a sudden commercial payers paid at Medicare rates, the total spending, health spending would go down by something close to $350 billion in 1 year. A large portion of that would go to employers, but more than $100 billion would filter back into lower premiums and costs for employees and others who purchase private insurance. So that's really making a point that, it's not as if there are many proposals out there that would go directly to Medicare rates, but it is to say that there is a cost to the current system, which has higher prices in the commercial market than we see in Medicare. I did take a look back at our side-by-side, which lays out Medicare for All and the public option and some of the different proposals that were introduced in the last Congress. And what's kind of interesting is many of these proposals acknowledge the sort of pathway to Medicare rates, but very few of them actually do impose Medicare rates. It's often a ratio of Medicare rates, or it's taking into account Medicare rates. So while there has been a lot of concern about what these approaches would do in terms of reducing private revenue with the assumption that they go to Medicare rates, it's actually less explicit than people might suspect. We know that states are looking at this. We know that some states, like Washington State, is moving faster than others, but I don't think there's any agreement on what the right amount is. But I do think what this whole analysis is that Josh, you presented, and then what we did as well, is it does help explain why policymakers are intrigued by this idea, particularly when the competition and the marketplace is simply not working well. And we know that's an issue in markets where there's been a lot of consolidation in the hospital industry. So I can understand why it's both appealing and attractive for policymakers, but also know that it was likely to encounter strong industry opposition, as the thought already does today. So the second topic I want to just touch briefly on is Medicare Advantage. I need to say that Medicare Advantage is very popular. It is in, if not in every district, it's close to every district. People like Medicare Advantage. Enrollment is now at 40% and rising rapidly. If current trends continue, Medicare is going to look more like a marketplace of private plans with a backup public option than a national public program that I think people think about it as it is today. There may be a debate. There is a debate going on about whether that's a good thing or not a good thing, but I don't think there's any debate about whether people should have the option of a Medicare Advantage plan. I think people recognize it's here to stay. So this is really a different question. It's not whether there should be a choice of a Medicare Advantage plan. It's really about how much to pay for it. And this issue has come up recently in the context of Medicare solvency, because part of the payments for Medicare Advantage plans come from the Part A trust fund. 40% of the dollars come directly from the Medicare trust fund. And so when there's evidence like there is from MedPAC and others that Medicare is overpaying for Medicare Advantage relative to traditional Medicare, that draws attention to whether or not this is an area where there might reasonably be some savings. I think, and I'm going to speak for MedPAC because I know Mike doesn't really want to, I think MedPAC is showing something like 100 that Medicare is paying 104% when you take coding intensity, coding into account relative to traditional Medicare for similar patients. And both MedPAC and the actuaries have said that Medicare Advantage is growing more rapidly per person than traditional Medicare. So this is kind of something that is raising attention. And I think it's something that does need to be looked at. I think, in an ideal world, everybody would like to have as many extra benefits as possible, but they're not evenly distributed across the whole population. And the higher payments for Medicare Advantage are being paid in part by everyone on Medicare in the form of higher premiums. And of course, it's having the effect on the trust fund, as we were just talking about. So I think this is another issue. There are many options that could be considered. The one that you put on the table is one that probably will be considered. And this is something the administration could do somewhat on its own. It's something Congress could take action on. But it seems to be an area that warrants more attention. The third issue I just want to mention briefly is prescription drugs. Because of all the issues we're going to talk about, this is the one where a great deal of the groundwork has been laid. The House passed a bill, H.R. 3, which had $500 billion in savings, and it lowered costs not only for Medicare, but also for people with private insurance. The Senate bill, or the Senate proposal championed by Senators Grassley and Wyden, had $100 billion in savings. The biggest difference is it didn't include the provision to give the Secretary authority to negotiate drug prices. But here you can see there is ground for compromise. Both proposals had the out-of-pocket cap on Part D spending, which Senator Crapo mentioned. Both addressed redesign and dealing with the sort of putting more pressure on plans when it comes to very high expenses and the reinsurance part of the benefit. And both proposals had provisions that would limit increases due to inflation. And that gets at the part that Mike was mentioning earlier. It's not just the costs that come in the launch prices, but also the annual increases, which have been an issue for prescription drugs. So I see this as an area where there could be opportunity in Congress, if Congress wants the opportunity. And I think there's also room for the administration to do launch models through the Center for Medicare and Medicaid Innovations. And I think with that, I'll turn it back to Joanne.
Okay, let's talk a little bit about bipartisanship. Do you see, which none of us have seen in many places recently, is prescription drugs the place where we might see it? And if you think that, I mean, we got stuck last year. The makeup of Congress is not all that different. President Trump was in favor of prescription drugs. Many of his ideas were really more aligned with Democrats. Gut check for all three of us. Start with Trish. Is there a conversation that can go more than 5 minutes on bipartisanship and prescription drugs?
I'm just going to be an optimist here. It's the start of a new Congress. I'm going to be a little bit optimistic that it might be possible, that members do want to come home with a win. It may not be all, I think the issue is the House has a bill that's far more ambitious than the Senate bill. It does align more with what the president campaigned on, because he too talked about giving the Secretary authority to negotiate prices, which is in the House bill, but not the Senate bill. But I think for a few reasons, there's a possibility, not the least of which is in this Congress, they may be looking for offsets for other spending priorities, and this could be an offset.
Okay. Mike, I mean, again, not in your MedPAC, but just as someone who watches this process, you see
above my pay grade. Yeah, my quick answer is it's above my pay grade. I won't speculate. I will say that some of the pressing issues related to the trust fund will force there to be some compromise. So whether that involves drug prices or not, I won't argue, but I do think that this is an area, because of the trust fund, where inaction is not possible. Dealing with some of the commercial price issues and some of the other things, maybe, but one way or another, they're going to have to think through, the policymakers are going to have to think through what's going to happen in the trust fund. And that's going to require some level of compromise. Where drug prices or Medicare Advantage or any of the things that Josh talked about fits into that bill, I'm going to punt to Josh.
Josh, you work in a bipartisan space. These ideas are things that we have heard Republicans and Democrats both talk about. These are not, Paul Ryan kind of restructure all of Medicare ideas. What are you, and it is a new Congress, and Medicare has a clock ticking. Medicare, the trust fund, not all of Medicare, but the hospital trust fund. It's, I believe, 5 years out now, or is it 4 fiscal years out? What, it's 2026, whatever it's. Maybe that's going to be a little better. Maybe it'll be a little worse as we emerge from the pandemic. What's your sort of, to the extent that you can take the temperature of a brand new Congress, starting in a very untraditional way? What's your feeling? Because I mean, I remember bipartisanship. That shows you how old I am.
Well, I mean, I would say a couple things. One is that there's a difference between bipartisan ideas and the final vote on something. So I actually do think there are a lot of bipartisan ideas for controlling prescription drug prices and controlling healthcare costs in general. I think we actually overestimate the degree to which recent, and by recent I mean the last 10 years of at least work on healthcare costs has been partisan. I think there's been a lot of underlying bipartisan agreement on the shift away from fee-for-service and the attempt to find new payment models. I think that was a pretty bipartisan consensus. So, I mean, I think ultimately for something on the trust fund to happen, I do think that will be bipartisan. But for some of these other things, it's possible that bipartisan ideas about how to control prescription drug prices wind up in a reconciliation bill that doesn't need 60 votes, for instance. So I think that's how I think about it. I also think that if you look over the long term, it's clear that Medicare is on an unsustainable path, as is the entire federal budget. And ultimately getting to sustainability will require bipartisan compromise over the long term. So I think both in the short term and in the long term, I'm optimistic that there will be bipartisan ideas for cost control. Whether in any specific Congress there is a bipartisan vote, such as the one we had, to change Medicare payment models, I'm not sure.
Okay, Mike, can you? Site neutral is one of those things again, and I'm going to be honest that my power cord fell out, and I'm going to duck for a second and get it while he answers, but it's only 2 feet away. Site neutral, it sounds like, to a normal person, it sounds crazy, right? You go to your doctor's office, you pay X. Your doctor's practices then gets bought up by your local hospital. Your doctor's now salaried or some kind of different financial relationship with the hospital. You go back the same year for the next year for the same exact procedure, and suddenly it's X times 5 or what, it's lots of X's. Nothing has really changed except how you bill it. Republicans and Democrats both.
Joanne, I think I lost you. Assuming that Trish and Josh did as well, I'm going to answer a question that wasn't completely asked. So obviously, again, I'm not speaking for MedPAC, I'm just reporting on MedPAC. MedPAC has been an advocate, broadly speaking, of site neutral payment, and the narrative that you were outlining was indeed the rationale behind a lot of that. I will emphasize that it is not always as simple as that narrative lines up, because there's differences in what services are bundled in. Sometimes there's differences in case mix across different organizations. So for example, if one wanted to think about site neutralizing ambulatory surgery centers with hospital outpatient departments, welcome back, Joanne.
Yeah, it lied to me. It told me I had 20 minutes, but it didn't. Okay.
I think I am answering the question you were about to ask. So
yeah, I mean, it's one of the craziest things in healthcare.
Yeah, I understand. So, and for the most part, I think many people agree. I think it's reflective of historically the fact that we built separate siloed fee schedules that weren't tied together in any meaningful way. And so we built a system as if there were hospitals and physicians that were completely separate, when in fact, hospitals now, the fastest growing part is outpatient care. They're buying a lot of different organizations. So you can see how this played out. You can understand why it's difficult to solve. Some of the other bills in the past have tried to solve parts of it. It is not always a simple thing to do if you think there's case mix differences, service differences, other types of things. But for the most part, I think moving to either site neutral payments or what I would argue, just a broader payment system that doesn't have so many silos is probably a reasonable way to go. And you see some of that through episode-based or population-based payments where it's a little bit less clear. And in fact, for example, if you look at Medicare ACOs, one thing that they do is they direct people to different sites of care that might be less expensive. On the commercial side, that's certainly true. We did some work in Massachusetts where when physicians had the incentive to shop, they sent people to more lower priced freestanding places as opposed to higher priced hospital based things. There's some complexities because the hospitals, and to people in hospitals, I want to say a lot of this sometimes seems like we're bashing hospitals. So I just feel obliged to say hospitals are really, really important. We knew that before COVID. We certainly know it during COVID. Everybody has to understand that we need to support a viable, high quality hospital system. It's just a question of doing that in a way that we can afford. And so taking money from them in any one of a number of ways to make things more efficient is what you'll hear a lot of. But we do have to make sure at the end of the day, they can survive and fulfill the mission that they have, because it's a really important mission.
Trish, is this like a low-hanging fruit, or is this, it should be, but because of all the interests involved? That's one question. The second question is, how much do patients even see this? Or is it because there is balanced billing, it varies a lot, that some people end up, one year you're paying $40, the next year you're getting a $2,000 bill?
Well, I would say this is not, I'll start with, I don't think this is low-hanging fruit. This is something that's been talked about for a while. There has been some movement in this direction, but I think there's strong resistance to further change. We already have grandfathered institutions, so I'm not sure. And on how much of this is transparent to consumers, I would say very little. You know, I think people really, you know, they do their best to track what kind of billing they get, what kind of cost sharing they get. Some people have supplemental coverage. Some people, I mean, it's just very hard to understand, not from provider to provider and from one year to the next. So I would say people might be shocked when things are more expensive than they expected, but without a clear sense of what's really going on.
Josh, in working in working with lawmakers and policymakers, as you try to communicate, you know, as you try to serve this role as a bridge, is this something that's like, well, we've been talking about it for, you know, X years, we give up, we're moving on to the next one? Or is it like, this is something that we can maybe tackle by partisanship because it's gotten so insanely out of control?
Well, I mean, let me say on the not transparent to consumer part, it might not be transparent to consumers, but it's certainly costing consumers. So, I mean, our estimate was Medicare beneficiaries could save about $140 billion over 10 years in terms of cost sharing and premiums. Private commercial insurers could save between $140 and $450 billion in premiums and cost sharing. So it's certainly costing everyone, even if it's not kind of obvious why those costs are in there. And I think that gets to what the pitch is to members of Congress to kind of fix the problem, because all of this is hard. Saving money in healthcare is hard, and that's one of the reasons why we haven't done it. But when you start to line up the things that should maybe go first in saving money, I think it should be those things that kind of don't make a lot of sense for the modern healthcare system, and the things that cost not just the government, but also individuals money. And so that's why this is there. It's not, I mean, we say it's low hanging fruit because it is kind of one of the more obvious perverse incentives, not because it is very politically easy. Because if it was politically easy,
Nothing's
obviously
politically
it would have been
easy.
done. Right.
Right. Nothing's politically easy. I mean, first of all, we're not in an era of cooperation. And secondly, Medicare is hard. I mean, every time you take money, it's hard. If it wasn't hard, we wouldn't all be employed. There's something coming up in Congress in the next few days. I think in the Senate, House this week, and the Senate has to be pretty soon because the deadline. The sequester. I'm going to let Trish try to explain this. Not try, she can explain it. I'm going to let Trish explain what this 2% is, and also briefly remind people that it is being separated by the larger pay-go. And it's being separated, the bill in the Senate at least, to separate them. I'm pretty sure it's bipartisan. I think it's Shaheen and Collins, which means you have at least one Republican vote, and presumably more on, well, you never know, but this should be something that we see bipartisanship from in the short term. Trish, can you explain why we're talking about a 2% cut to Medicare in the middle of a pandemic, and why it probably, well, you let us know whether it's going to happen or not, and remind people some of the work you've done and how much money has gone into the healthcare system during the pandemic. It's
Okay.
I have here.
So
a circle chart here from you somewhere. It's 137 billion before the last.
Well, it's like 100. Yeah. Okay. So the idea of pay-go and sequestration has been around for decades. So this is not a new concept, but it's coming up it's coming up, as you said, this week. There's sort of two separate thoughts here. So there are two paths. One is pay-go, and pay-go stems from the Statutory Pay-as-you-go Act of 2010, which required the administration to impose spending cuts if Congress passed a law that either increased spending or reduced taxes in a way that increased the deficit. It would require something to happen, that the administration was caused to happen. I need to say that this has never happened. I believe it has not happened once, and that's because Congress has enacted legislation to stop it from occurring. The next year,
the Congress, that's Congress. The Constitution calls that kicking the can, right?
Yeah, well, something like that, or pretending there was no can. Secondly, there's the Budget Control Act, which was passed the following year. The Budget Control Act was set up to create a committee to reduce the deficit, but there was this kicker in there which says if they can't come up with an agreement, there would be sequestration. And the sequestration was to occur, and by the way, there was no agreement, so that kicked in the sequestration requirement, which was to run from 2013 to 2021. In the years since then, Congress has extended that time period. And I'm gonna swoop up to where we are right now, which is we were in a year where there would have been a 2% sequester on Medicare to reduce payments to Medicare plans and providers across the board by 2 percentage points. That didn't happen because the CARES Act, in response to the pandemic, decided to waive the 2% Medicare sequester through the end of 2020. And that was followed by the Consolidated Appropriations Act, which extended the waiver through the end of March. So when you say, it seems like we're at a time when something's going to happen, if Congress doesn't extend this waiver, that would mean payments would be reduced by another 2% as it would be required by the Budget Control Act and sequestration requirements. So there is a bill that is pending, and I think going to the Rules Committee this week and maybe to the House floor this week, that would extend this waiver so that it would not require the 2% reduction until the end of this calendar year. So that's one thing. So that's the sequestration part of it. There is a second component of it that says, hey, by the way, we also want to exempt the American Rescue Plan Act from pay-go requirements. That's the first law that I talked about, so that wouldn't kick in a reduction in payments. That was not included as part of the Rescue Act when it passed Congress a few weeks ago, was it?
It's all a blur.
It's all a blur. Every day's a blur, because I think it would have violated the Byrd Rule, among other reasons, but that is also something moving through. So in terms of the sequester, I mean, I think there's a question on the table. Providers have pushed very hard to not have the sequester come back and take effect. And there is some debate about whether or not that's a good idea or not. Congress has done a lot for healthcare providers over the course of the pandemic, and rightly so. There was the Provider Relief Fund with, I want to say, $78 billion, most of which went to hospitals, but also skilled nursing facilities and other providers. Congress bumped up payments for DRGs associated with COVID by 20%. There were the accelerated and advanced payments, which moved money earlier to providers where they lifted the sequester, as I mentioned. And I think there was a recent bump in payments for rural hospitals of about $9 billion. So, you know, this kind of shows the dilemma when we talk about timing and talk about payment reductions. There doesn't seem to be an appetite at the moment for payment reductions when we're still in the thick of the pandemic, not quite in its wake. And so at the moment, Congress seems to be in the mood to do everything they can to keep providers whole or more than whole.
So it's unlikely. So it's likely we will see the same kind of postponement of these cuts. Does everybody agree with that? I mean, we've been seeing them postponements when we weren't in the pandemic. So I would imagine it makes it harder. I mean, Mike, you're nodding.
Well, a few things. The first thing is, I'm going to again avoid the politics of this. There's obviously a lot of politics for people getting more money, and there's a lot of sympathy for providers in the midst of a pandemic, who I will add have done an unbelievable job, given they were the front lines of a really unprecedented situation. And what they had to do was really remarkable. And I think that that needs, you know, they're not called sort of heroes in many ways lightly. That part being said, the sequester is an unbelievably blunt tool. So this is true about an enormous amount of policy. And the challenge is that you don't want to use blunt tools as often as we do use blunt tools. So the sequester, or its delay, if you will, is a mechanism that works easily because it has this sort of process to go forward, but it doesn't give you the level of nuance you would like. And I think if you look at many of the things that Tricia was talking about, the CARES Act and all the following on aid, I think a reasonable complaint could be, it could have been targeted better. Now, I understand time was tight, there's a lot of issues, but dealing with that targeting is a core policy problem, and our both political process and frankly, some of the underlying tools we have don't make that an easy thing to do. So I won't predict what's going to happen, only to say that some types of providers and some providers, even within types, have a better case than others. And we don't have a policy system that allows us to play that nuance. So we have to decide how much do we want to pay for some that might not need it, in order to make sure it's those that do get it.
I think one of the interesting things about the issue briefs, and the speakers have referred to these 3 briefs, that first of all, they are in fact brief. Those of you who are used to getting a brief in your email and you click on it, it's 200 pages. These are brief and they're very clear. They were very useful for me to read them. But I think, and Mike, you're also part of the 1%. What's the exact title? The 1% Solutions for Healthcare? Is that? It's a whole bunch of really interesting economists collaborating across universities and institutions. I get nostalgic when I think about it, because the very last dinner I had, a professional dinner with interesting conversation, a group of people talking about ideas before the pandemic. The last one I had was when Zach Cooper and his pals launching this thing last year. And someday we'll be 3-dimensional again. But like the ideas here, well, why don't you explain it? You're part of the project briefly, because it follows up what you just said about not blunt instruments. Blunt instruments, A, are dumb ideas, and B, they didn't get us anywhere politically, right? It was just another game of finger pointing and kicking the can. So
can I interrupt real quick?
Sure.
But just before Mike goes into how to not have blunt instruments, as the budget hawk, let me just put in a plug for blunt instruments, where Sometimes because you have such concentrated, intense fervor against things, the only way to accomplish something is through a blunt instrument, because then everyone shares the pain equally. And I think in the case of this Medicare sequester, the 2% sequester, we have offered ideas, and there are plenty of others out there for them to kind of pay for it for however long they want to extend it. But then I'll let Mike
But
jump in.
you also put forth three really interesting ideas, none of which are easy politically, none of which are eensy weensy. They're all billions and hundreds of billions of dollars, most of them. They're big ideas. They're intriguing ideas, right? So, I mean, that conversation, you may be going. There may be multiple conversations needed to get people to the goal of a more rational trajectory of healthcare spending. But Mike, just briefly explain what 1% is, because I found it really quite interesting.
Well, I think the principle behind it, and Zach Cooper's the person who should be discussing it, is that we sometimes look for broad overarching solutions when in fact we're going to build a mountain of savings pebble by pebble. And so we asked a lot of people to come up with ideas for pebbles, if you will, and they involve relatively minor changes in how we pay for some parts of drugs, relatively minor changes. By relatively minor, I don't mean unimportant. So I don't know who's listening. I'm about to get hate mail. I basically mean 1% orient type things, some stuff on kidney transplants, our point on prices was in there. So there's a lot of small things, essentially that fits into Josh's point about you want efficiencies and then let them add up, as opposed to just big savings. I think Josh's point he made a moment ago, and I'm not sure Josh and I agree, it would be nice to be in person, we could pass notes, is there's a political merit to having some big blunt things to hold everybody's feet to the fire. There's some virtue in the trust fund and making sure everybody comes together. But if you want to get to efficiency, seldom are you going to get to efficiency through across the board fee cuts, for across the board fee setting, for across the board utilization reductions. There's usually a lot of smaller technical things that add up. And that's the idea behind the 1% solution, is to come up with some of these things that in their targeted areas are important, but the target areas tend to be narrower. So when you look at any given thing, you don't get a lot. And the problem is often, and this is, I think, the key point in some ways, many ideas are shot down because someone will say the juice isn't worth the squeeze. But it turns out if you don't squeeze any oranges, you never get, you got to squeeze a lot of oranges to get a glass, right? And so to some extent, you're just going to have to do that small work, because if you're looking for the home run, we have a long way coming, in my view, to get to the home run.
Josh, do you want to respond or add to? It's not argumentative, but thoughts?
Yeah, I mean, I don't disagree with really anything Mike said. I would say that when, and you might get to this in later questions, but if we look forward to see how we're actually going to start achieving some of these things, some of these cost savers, I think it will be in these incremental moves, because we can use these policies to substitute or to pay for policies that Congress does want. So the recent Affordable Care Act expansions from the rescue plan are going to have to be paid for eventually if they want them to be made permanent. And that's why collecting a lot of the ideas that Mike suggests, collecting the ideas that the Health Savers Initiative talks about, CRFB also maintains a budget offsets bank that is always available to members of Congress. So I think our point is that these incremental steps are important, and they can be used to pay for other things and ultimately to help lower costs over the long term. But that original Medicare sequester was created because Congress couldn't agree on those individual things. And at least it set us on the path towards saving money and eventually holding them to the fire. Because if they do wind up paying for extensions of the delay, that's at least getting us a little bit of kind of fiscal sanity in the mix.
The conversation in Washington in terms the sort of macro conversation changed in the last couple of years. It changed during the Trump administration. We didn't hear a lot of talk about deficits. You still did, but it just, you just heard, if you were to do a word search of the congressional transcript for the last 4 years, it would probably be like the fewest times the word deficit appeared in like 50 years. So, I mean, I'm not suggesting anyone tries, but you get the point. We have a different conversation. It may be about to switch back. The party alignment is different. The climate is different coming out. We have a lot of economic damage from the pandemic. Do you see, I mean, that, and then that if you're trying to find steps forward, and both parties understand there's a problem with Medicare, both parties understand, I mean, for different reasons, why they want, people have different priorities, different parties want to restrain spending for different reasons. They both want to restrain the spending. Is it sort of a window of opportunity to try? I mean, can you? I'm not articulating this well. Does this lack of concern on the deficit and the fact that we're probably going to hear about it soon, does it change the kind of policy options that are on the table? There, I got it out. Josh.
Well, yeah, I'll start. I mean, one of the reasons why I started out 20 years ago doing fiscal policy and worrying about the deficit. And throughout the course of my career, I've gotten more and more focused on healthcare specifically, because I think this is an area where there is a call to action on healthcare costs and healthcare system efficiency that is really not related to the deficit. It is that we have a uniquely inefficient healthcare system where outcomes are not as good as most of our peer countries, even though they spend less. And this hurts individual Americans, it hurts businesses, and it hurts the federal budget. So I think, there are reasons to want to change our healthcare system that are not related to the deficit, because we want to make everyone's health better. We want people to keep more of their money in the form of wages, not for health insurance. And so those are reasons to attack this separate from the deficit. The fact that the deficit might now become at the forefront of, or not at the forefront, but higher on congressional discussions, I think is in part because of the political changes, but also it's pretty undeniable that we've added a lot of debt over the last 10 years. And I think it is also undeniable that that can't continue forever. So we really should want some action on this. And I know economists differ about the degree to which that's important right now versus over the long term, but you will find very few economists that think over the long term we can keep on the current trajectory. So I think all of those things combine to wanting us to fix our healthcare system.
Yeah, even if you're not an economist, if you happen to be the daughter of an economist, you can see those charts, you can see the trajectory. And at some point, okay, those looking 50 years out in some ways is a fiction because things do change, but there'll be no money left for anything else, right? That the trajectory we're on is unsustainable, though, as people keep pointing out, they've been saying, people who've been in this field for a long time saying they were telling us it was unsustainable 30 years ago and we're still doing it. So, but several of you brought up things about quality. I mean, I think that the real point is not just how much we're spending, but how are we spending it and what are we getting for it? Are we getting health? Are we getting improved health? Or are we just throwing money to crazy policies? So CMMI is now about 10 years old? I can't remember exactly. It was created in ACA. I can't remember what year it actually opened, but roughly a decade. We have a new director coming in. Again, this was something while we were having this mega conversation a number of years ago about more cuts and more blunter instruments. We were also having a conversation about value versus volume, or quality versus quantity, depending on how you wanted to talk about the move away from fee-for-service, trying to get more value for a healthcare dollar, trying to make sure that we were spending it on something you need and would help you or help the patients. It was also the idea that we were going to throw a whole lot of ideas out there. It was like sort of an accelerator. You're going to throw a million ideas out there, and then you're going to figure out which ones were worth pursuing. I remember Bob Reischauer, who would have told you that he was a fairly pessimistic kind of guy, thinking, well, there's so much we're throwing at a wall, something's going to stick. I feel good about this, right? Liz Fowler is about just taking over, new administration. I mean, this has not been a particularly political office. There have been bipartisan work going on. There's been things, it's been a space that all kinds of people have worked in. But are we at a different point now? Are we at a point where it's like, all right, we've been throwing stuff out there for 10 years now. What should we focus on? I mean, do we go back to figure out how to making ACAs work? Is the model good? I mean, I'm not asking you to get this granular. You know, maybe the model, the plan ones didn't work so well. Maybe the physician ones are the hot thing now. The physician ACAs seem to be an area. Is it, you know, are we going to do all bundling? Right now, we're doing all of it. You know, there's just a million things going on. And I suspect that there will be more work done on drug prices because there are things you can't do through Congress that you can do as a great big fat demonstration project in Part B or Part D. What would each of you like to see the next iteration of CMMI? You know, is it do everything? Is it choose two? I mean, just that's an overstatement, but you know, Trish, let's start with you. I mean, we haven't solved the quality value problem in Medicare. Any one of us who's had a, you know, experience with a loved one who was of Medicare age can attest to that. So, and every American, you know, many of us have. Is this still a useful tool for economics, or is it going to be a tool just for improving quality? Where do you want to see it going?
Well, I do think it's useful, and I think that's like a I don't think I would want to choose one or the other. And I think I'm going to let the others talk about ACOs and bundling and talk more about new opportunities. CMMI really hasn't touched what we can learn from Medicare Advantage to improve traditional Medicare. And I think there are real opportunities there. We hear a lot about coordinating care for chronically ill patients. We hear about efficiencies. I think really digging in to test different payment systems, to learn about quality, quality successes or not would be very useful, and then to apply those in a model to traditional Medicare in a new fashion. Also, you mentioned prescription drugs. I don't know whether or not what the timing will be, because they may want to wait for Congress to do something. There are still some things, residual models from the Trump administration that are hanging around in the courts, which may or may not see fruition. I saw that they just pulled something yesterday about the protected classes, but but certainly prescription drugs, if Congress doesn't act, is an area where I think we could see more creative activity out of CMMI. And then there's this whole area of long-term nursing home quality, post-acute care quality, and payment, which has just blown up during the pandemic. But for those of us who have been watching what's been going on in nursing homes for years, this was a long time coming. It's very sad that it took a pandemic and the consequences of the pandemic to make us all pay more attention. But I think this is also an area where CMMI could help us move the needle a little bit.
Mike?
Yeah, so I have immense passion around this question, so I'm going to wait until you pull the plug and then I'll stop talking.
No, it's interesting. I mean, it's got huge powers and huge potential, and you know what you do.
So I wish there was a banner again that said, "This is Michael MedPAC." But for those of you listening, there will be a MedPAC session on this topic in April, and there was one in March, and we will hopefully be having a vote. So my personal view is that the paradigm of test and diffuse is no longer the best paradigm. That we're at a stage where we need to have a vision of what we want Medicare payment to look like. You can pick your year, 2027, whatever it is, and think about how we're going to move there in that direction. I think that the constant testing and launching of new models ends up being, at this point, distracting in a bunch of ways with a whole bunch of different tweaks to existing models. I think there's a number of improvements to the existing nature of the models, but the details are, in my view, a little bit less important than having a vision and working towards it. I think that Liz Fowler, you mentioned her a moment ago, is a terrific choice to head CMMI. I think CMMI was intended to really allow innovation in Medicare and Medicaid. I don't want to dismiss Medicaid. I think it's an amazingly important program. And so I think the main direction is to both have a vision, work towards the vision, and then create, there's a bunch of things that I would call quibbles with the nature of the models, how the benchmarks are set, how much risk is imposed, the overlap in the models. I'll save my joke for something that I'm going to publish in a little while, so it'll be fresh when people see it. But I think the key point here is that having a bunch of overlapping similar models is at a point now where it doesn't help us. And in fact, if you launch 5 models and test them all versus nothing, say all versus fee for service, and find out they worked and launch all 5 of them, you're not going to get the same results because they interact in a whole bunch of ways. So you really need to think about what I consider a consistent, transformative payment landscape, or what I usually call a portfolio of payment models, and then work towards building that. And we will have to have another discussion about my personal view about what that portfolio would look like. But I think more important than what it actually looks like is that you actually work towards that as a direction.
Josh, how much of a tool is it for the fiscal goals fiscal and quality goals you're trying to achieve?
I mean, I think it certainly started out as a tool. I think that, I mean, everything Mike says on this is much better than what I would say. And the MedPAC discussion of it a few weeks ago was fascinating, because I really do think that after 10 years, it's a good time to look back and see what we've accomplished and what we haven't. I think the idea of just continuing many different voluntary models is not going to continue to tell us much. And so that's why I do think some changes were made. I think if it was my preference to go back 10 years, I would have had a lot more voluntary models. I mean, a lot more mandatory models, so that we could have done some real testing. And but I think what happens is, like all of this stuff, saving money in healthcare is hard. There is no silver bullet, no matter how many demonstrations we try to find out what the silver bullet is. I think demonstrations were very interesting to kind of learn about what providers might want to do and what they would kind of shy away from. But I think, again, to get savings, we need to make some harder choices, make some things mandatory, and start pulling some money away from some people in the system in order to have a less expensive system. So I really do look forward to MedPAC kind of figuring out what their recommendations are going to be on this. But I know that Liz Fowler will guide CMMI very well, and I do look forward to seeing where they go over the next few years. One other thing about this is another place that was relatively bipartisan. It went from the Obama administration to the Trump administration and now to the Biden administration. And really, people might quibble around the edges, but I think there was a consistent dedication to kind of rigorous excellence and trying some good things that I think portends well for future efforts at healthcare cost control. I really do.
I think it's the only significant piece of the Affordable Care Act that they never tried to repeal specifically. I don't think there was ever a vote. There were a couple of letters here and there. I don't, maybe someone remembers this. I don't think they ever was a vote to repeal CMMI. I mean, it would have been repealed as part of if they repealed everything. But I think it has had, I think, Josh, you're right. I mean, I think it's had an unusual amount of bipartisan. But we're going to get toward the, we're going to wrap up. I'm going to ask one question because it's in the news. Most of our audience is still with us, so thank you for keeping this interesting. It can be hard on Zoom. We all know that by now. But there's two things going on right now. They just made the Recovery Act made the first expansion to Obamacare. It expanded the subsidies, it changed the structure, it created some incentives for states the holdout states to do Medicaid, although I don't think any of us think all 12 of them are going to rush to do so. They're only for 2 years, most of these changes. Congress is going to have to grapple with how and when and how to pay and the politics, et cetera, to make them permanent. The Democrats clearly want them to make permanent. But the other thing that's going on is beginning to be a discussion about the public option. It's just beginning. We're seeing bills dropping, and we're seeing a conversation about, are they going to do it? When are they going to do it? All that. I don't want to talk about the politics. I want to ask a question about the economics. And we are also noting that today, some House Democrats, about half of them, are reintroducing Medicare for all. We all know that the president, the Democratic primary was partly about Medicare for all. President Biden does not want Medicare for all. Secretary Becerra, who presumes Secretary Becerra had been an advocate in the past and now says, he's going to work with President Biden on improving the ACA and public option. So quickly, put aside the politics to the extent you can. Is the public option, can it be designed to save money? Mike?
So yes, the public option can be decided to save money, but remember that saving money is also cutting people's revenue. And when you do that, you have to worry about a lot of unintended consequences. So the public option is one of those things where it has different meanings in different ways for different people. So it's not like the public option. Maybe you need to ask us, what should we do about the public options or different proposals? Short answer is, it can obviously save money. Whether that's a good thing or not is not the question to ask 5 minutes before the end of the session. And in case, I will just close by saying, the important thing to remember here is, although we should try and save money at every chance we get when we become efficient, our real challenge is slowing the rate of growth in spending. So we may be able to solve some of our problem without actually cutting a lot, just by slowing what is projected. And this nuance between cutting versus slowing growth is way more important than we've given it attention to here.
Which was what, the bending the curve of 10 years ago, which sort of fell off the curve or whatever. Trish.
Yeah, I would agree with that. I went back and I looked at some of the public option proposals this morning and sort of, because I was interested in the payment issue, and they really differ. So it's really hard to say, yes, it's possible you could pay Medicare rates to providers in the public option, which very few proposals would do. And that would help control costs, and it would be less expensive, presumably, than the marketplace, which is paying higher rates. But whether or not that's what's on the table is not clear. So I'm kind of with Mike there and saying, it really does depend. And I know that's a boring answer, but these aren't even details that matter. These are like basic provisions and how they're set up.
Josh.
Yeah, I mean, I'll just say everything that Mike and Tricia said, I would say, but also I do like when, I talk to regular people about healthcare issues and try and explain things. The real thing to point out with the public option and with Medicare for all is that most of the savings come not because the government is more efficient at administering insurance, or the public option because it's competing and cutting down profits of commercial insurers. It's because they're lowering prices. And that's one of the reasons why we picked hospital prices as something to focus on in our options. And so a Medicare for all or a public option that saves money probably saves it because they're allowing themselves to pay hospitals lower rates than commercial insurers currently have to pay hospitals. And so whether you want to cap prices for the commercial market or whether you want to have a public option or Medicare for all, it's all about those hospital prices and to some degree other physician prices as well. It's not just because all of a sudden the government is coming in and competing against a bunch of other insurers on a marketplace. So I think that's something that people sometimes don't quite understand. And once you understand that, I hope you have a better appreciation for why these are not easy bills to pass, because they are incredibly difficult for this reason. This is a big tension in the healthcare system. To what degree do we save money by lowering prices, and to what degree do we save money in other ways?
So that you're basically saying that the selling point has been that the public option would create competition in the exchanges and therefore bring down prices. And all of you are saying it's the price is stupid. Or the price is smart, people maybe. that the public option depends. It's benchmarked to Medicare, some percentage of Medicare, and Washington State, which is the only state that's done one. I think they ended up at 100. Was it 135% of Medicare, or was it higher?
180.
Oh, they started at 130. Politically, they ended up at 180. So that's just going into effect now. So I wanted to just, it was an interesting conversation. There were interesting briefs. I do think that we are in a beginning to hear, I mean, maybe we should really be optimistic in the fact that we're all sitting here talking about something other than vaccines could be a sign that we're actually going to get out of this. Thank you all for participating. Thank you to Josh for having me join you. I learned by preparing for this, for getting out of vaccines and pandemic, and which is so much of my work these days, and sitting down and reading these briefs and thinking about these things. I learned a lot. So thank you for having me. Thank you for having an interesting conversation. And as is mandatory to say nowadays, I hope everybody stays well.
Thank you.
Thank you. And thanks to the audience.
And stay well.